content. This is Benjamin. Is Benjamin. And in this video, I'm going to be talking about the breast tumors and concentrate on the aberrations in wound development and revelation. So, when the breast is developing and a child is born is predatively almost no breast tissue, and slowly over the years, the breast tissue starts to form, and the breast is composed of majorly three tissues. That is the stroma, the fat, and then we have the ducts and the alveoli. So, as puberty approaches, there starts to be development of the breast tissue, and in the earlier periods, it's going to be majorly the lobules and the ducts that first develop, and around the beginning of the menstrual cycle, or when someone becomes menstrually active, the tissues begin to increase with the stroma and fat deposition. And then finally, after menopause, the stroma tends to increase and is more fat deposition within the breast. So, when you look at the aberrations in the normal development, we can group them into three: the early reproductive period, that's 15 to 25 years, the mature reproductive period, around 25-40 years, and then the involution period, that occurs from around 25 to 55 years. So we're going to have the breast and going through the cycle whereby different hormones come into play to prepare them for pregnancy. At the intention of pregnancy, we have to revert back to the normal, so the changes have to involute. So during the early period, when the lobules are just beginning to form, sometimes we have the conditions whereby one lobule, remember a lobule has different alveoli inside it, or different glands inside it that are producing the different the milk. So in these lobules, if one lobular unit undergoes hypertrophy alone and enlarges in size, most of the times you have a formation of a fibroadenoma, which will appear as a discrete lump. And this is considered fairly normal, even if some people may not have it, but most people actually do have a lump. And this discrete lump is called a fibroadenoma. And it's not yet a disease state until it is greater than 5 centimeters, where we consider it a giant fibroadenoma. As well as the stroma, as the stroma is being formed now. The stroma is the connective tissue in the breast. Sometimes we have increased hypertrophy of this stroma, which we call the juvenile hypertrophy. And when it increases to increase, the stroma is going to cause excessive breast development. And when this occurs, we can have things like multiple fibroadenomas occurring. We can have submammary abscesses, or we can have mammary fistulas. Then during the mature or the reproductive period, that is around 35 to 40 years, we have the cyclical hormonal effects on the glandular tissue. So every time during the menstrual cycle, we're going to have estrogen and progesterone acting also on the breast tissue. So sometimes they will have exaggerated cyclical effects, and this can lead to generalized or discrete lump formation, where we can have either one lump or very many lumps. And when we have very many, we pain all of the cyclical nostalgia with modularity. And sometimes it's incapacitating. The pain is too much that someone cannot actually do anything else. Then also, because of the formation of the hormones causing a lot of glandular tissue to undergo hyperplasia, sometimes we have rupturing of some blood vessels, and then we have bloody nipple discharge. Then after menarche, or in the late period, or even after during the cycle when the hormones are low, we have to have involution. And when we fail to have involution or returning back to the normal state, we're going to have things like macrocysts forming. We can have sclerosing lesions, which is fibrosis, because sometimes these cysts go ahead and burst, and in the past they cause some inflammation. The inflammation leads to sclerosis. And sometimes, because of failure to involute, we also have adenosis. which is an increase in the number of glandular tissue in the breast. So this can give us things like discrete lumps within the breast, and sometimes we have extra abnormalities. But these are majorly what we call cystic diseases. So these cysts will normally be fluid filled. Then we have, when it comes to the duct unit, the ducts also expand and decrease. They have the myopithelium, which is important in the to squeeze the secretions or propel the secretions out of the ductules and the lactiferous ducts. So this myopithelium at times lose their elasticity, and this is why this is going to cause their dilatation. And when they have dilatation, means things are going to always accumulate, and sometimes it's going to lead to a nipple discharge because things are going to take long to be expelled. Things will stay within those ducts, and then later when they are full, they'll be discharged. And sometimes we have some kind of infection, and that infection is going to lead to inflammation, and the inflammation is going to be fibrosis. When fibrosis occurs, there is shortening of tissues. That is going to cause nipple retraction. Then things like the ductal mastitis will also occur, which are have infection, which are have lactational breast, and mammary duct fistula. Then also during involution, we have epithelial turnover, whereby the cells, the epithelium that lines this duct has to actually change, and sometimes abnormally there is hyperplasia of this epithelium. So we have the wall going on, increasing in size, and then we have what we call epithelial hyperplasia with atypia. And this is very important because as we have atypia, it means the cells are starting to change, the tally to mutate, and this can cause the precancerous lesions. So look at the fibroadenoma, it's a benign ANDI or a benign abnormality of normal development and involution, where we have, which occurs in around 15 to 35-year-old women who are hormonally sensitive, and it occurs as a result of exaggerated lobular development from estrogen stimulation. And the features of a fibroadenoma is that it's firm, it's mobile, and it's non-tender. And sometimes it's called the breast mouse because on palpation, as you try to actually touch it, most times it disappears. It is smooth and well-defined and not attached to the skin, and it may emerge during pregnancy and regress after menopause. So some of the differential diagnoses are Phyllodes tumor or carcinoma. Then we're going to investigate it by doing an ultrasound, which is a which I'll say a well circumscribed lesion. You can do a fine needle aspiration cytology or core biopsy, which will show by physics structure, which is a stroma and the ducts. So the treatment, if it's less than 3 centimeters, we are normally going to reassure that this is a normal variation. And if it's greater than 3 centimeters, or if it's greater than 5 centimeters, which we call a giant fibroadenomas, or if they are more than 5, or rather if there are multiple fibroadenomas, it's also an indication for surgery. And the prognosis is normally good and excellent, and it's normally not a precancerous lesion, so the malignant potential is almost not there. Then we have fibrocystic adenosis, or what we call cyclic myasthenia, and this one is a benign estrogen-dependent fibrosis, where we have deposition of fibrous tissue, cyst formation, adenosis, which is an increased amount of glandular tissue, epitheliosis, which can be accompanied by papillomatosis or cyclic myasthenia. So when you look at this, we're going to have estrogen coming in during the early phases of the menstrual cycle, and this estrogen is going to cause proliferation of the breast tissue, mostly the ductules and the ductules and the ductules and the lobules. So when this increase in size, and we pass from the hyperestrogenic cells to a state where estrogen causes during the cycle, these are expected to actually go back to the normal size, especially if there is no conception and the baby is not conceived. So we expect this to go back to a normal size, but what happens is they don't. And for some reason, these people want to also have decreased levels of progesterone. So the rate of involution, or the rate at which these lobules go back to their original sizes around good. So what happens is that they remain engorged. And when they remain engorged, sometimes they end up bursting. And when they burst, there goes an inflammation which leads to the fibrosis. And this basically gives us the clinical picture of the disease, and it's going to be characterized by cyclic pain, breast pain, and when it touches the breast, the patient is going to have a lot of nodules. So it is the most common disorder, and most times it's bilateral, and the upper outer quadrant is affected the most. So clinically, it's going to be, we're going to have bilateral tender nodules. That means in both breasts, we're going to have nodules. Cyclic mastalgia, which means the pain is going to be on and off during different times of a menstrual cycle. And then we have a serous green or bloody discharge. And this is due to the hyperplasia of these ducts and nodules. Sometimes the hyperplasia can cause the blocking of the ducts as well, the epitheliosis, because the epithelium is found in the ducts. So when there is epitheliosis and these ducts are blocked, things are going to hold in there, and then when they are discharged, we are going to have those different kinds of discharges, the serous, the green, or the bloody. And the blood is going to come from rupture of blood vessels, because this new tissue, the hyperplasia, requires some new blood vessels to be formed, and when they are formed, sometimes they are weak and they rupture, so the bloody discharge. So we have a classification where we have the non-proliferative, whereby we have no cancer risk. If there is no proliferation of epithelial tissue, then you have the proliferative with atypia, without atypia, which carries a very mild risk. Then you have a proliferative with atypia, which has a high risk of proceeding to breast cancer. And then the stages, we have stromal hyperplasia. Then this is going to be followed by adenosis, which is including the glandular tissue. And then these are going to form cysts. Then we have a special kind of cyst, which is called the blood-good cyst. And this one is going to be dense, it's going to be bluish, and it's also a big cyst. It's also called the Schimmelbach, the Schimmelbach. These are going to be the small cysts. Then when you do histology, if there is usual hyperplasia, that is 1.5 risks. And atypical ductal hyperplasia carries a 5 times more risk. Then atypical lobular hyperplasia, 20% chance in 10 years of developing breast cancer. Then the investigations you can do find the patient cytology. We can do the ultrasonography, where we can see a cystic or a solid lesion. Then you can do the mammography. The management is going to be conservative, and we're going to give reassurance, supportive bra, avoid caffeine, chocolate, or salt. Then the drugs, we can give the evening primrose oil, which has a combination of linoleic and linoleic acid, which is found to have some immunomodulatory effect on the levels of estrogen and progesterone. And they can give gamolenic acid, danazol, bromocriptine, tamoxifen. And when you look at all these drugs, they're almost just modulating the levels of estrogen. And we can do surgery, where we can do cyst excision. We can do a subcutaneous mastectomy with prosthesis if there's persistent recurrent bloody fluid epitheliosis or severe pain. And the prognosis is normally excellent, but it could be bad if we have the atypical hyperplasia. The mesclerosing hydronesis, where we have polycentric proliferation of the acini, is stronger fibrosis. So the acini are the milk producing units within a lobule. So in this increase, and we have also stronger fibrosis. We have sclerosing adenosis. So we have exaggerated involutional proliferation, and this may mimic the carcinoma. And when you do a microscopy, we have compressed acini, because there are very many, and the dense fibrous stroma. So the stroma around the acini is also dense and fibrous, but we have preserved topular architecture, and sometimes we have visible microcalcifications. Clinically, it's going to be a found non-cyclic nodule that is always going to be there. And sometimes when do mammography, there is going to be some calcifications. Significance is that there is slightly increased cancer risk with sclerosing adenosis. The management want to do a core biopsy and then do conservative follow-up. Then we have duct excision, like I explained previously, the duct aligned by my epithelial cells which hope to contract and relax, allow that contraction and relaxation of the ducts. So what happens is that sometimes we have duct loss of vertical elasticity and we have duct dilatation, and this is going to cause things to stay there for a long time, and the stasis is going to lead to inflammation. So it is most common in perimenopause women, that is 40 to 60 years. And the pathophysiology of this ductostasis due to decreased duct elasticity, leading to inflammation and then fibrosis. And when this occurs, we can have clinical picture like a subareolar lump behind because behind the areola we have a lump. We can have a greenish or brown nipple discharge because I've told you things are staying there for a longer time. They be discharged later. So most times they are distorted. Then you have nipple retraction because of that inflammation causing a fibrosis that pulls on the nipple, causing retraction. When you do imaging, we can do ultrasonography where we see dilated ducts and debris within them, and a mammogram we can say subareolar density. When you do histology, we have dilated ducts still, chronic inflammation and leading that the macrophages. Then management, you want to do NSAIDs, you can do a warm compress, and if it's persistent, you can do duct excision, and if there's an infection, we can as well try to use antibiotics. Normally it is benign and there's no cancer risk, but it may mimic subareolar carcinoma because of rectal hardness that's found. They may have the Phyllodes tumor, which is the rare fibrocystic breast tumor because of like abduction. This covers almost just 1% of all breast tumors, but it's very important. And it can be benign, malignant, or borderline. So it occurs mostly in women 35 to 50 years old, slightly older than the age group that expresses a fibroadenoma. Sometimes it can start on its own de novo, or it can come from an existing fibroadenoma type that it undergoes changes later on in age to actually go to this Phyllodes tumor. The result is that there is cover growth of the stromal component of the breast, and it can behave aggressively if it's malignant. So the features is that it's going to be rapidly growing, faster than actually Fibroadenoma, the painless, the firm breast mass, and sometimes it's going to cause scratching of the skin, and in large tumors due to pressure effects it's going to cause ulceration. It may mimic a fibroadenoma, but it's important to notice that fibroadenoma grows slowly while the Phyllodes grows very fast. In an imaging and mammography, you can say, well, circumscribe the dilated mass on ultrasound. It's a solid heterogeneous cystic species may be present. Then in histology, they reflect stroma projections from my device, the name Phyllodes. Then the stroma, it is cellular and borderline or malignant, and the mitotic activity is also increased. So we can have the classification of the Phyllodes tumor from benign, where they look at the stromocellularity, where it's mild, and then the low mitosis, that is less than 5 per 10 HPF. Then when you look at the borderline, there's moderate cellularity, and there is about 5 to 9 mitosis per 10 HPF, and there's also mild atypia. Then the malignant one has increased stromocellularity and greater than 10 mitosis per 10 HPF, and atypia, as well as you can see some infiltrative lesions. Then the management is going to be surgery, where we do wide local excision with greater than 1 centimeter margins. We do not do axillary dissection because it rarely really spreads to the nodes. And the recurrence in tumors may recur locally, whereas the malignant ones may actually metastasize to the lungs and the bones. And the key differences between this and the fibroadenoma is that it has a faster growth. The Phyllodes has a faster growth, and it occurs in an older age group. It has a leaf-like stromal architecture on histology, and it has recurrence potential and possible malignancy. So we are completing endohistory, and we have looked at the benign breast tumors, focusing on the operations in normal development and ovulation. We shall meet in the video about breast cancer, where I will discuss the anatomy a bit more deeply, and we try to see the differences between the benign and the malignant breast tumors. Thank you. My name is Benjamin.